Good morning, everyone, and welcome to our VA presentation on suicide prevention. We are very fortunate to have Christina Allen with us, and she will be your presenter for the next hour? Yeah, about an hour. Happy Valentine's Day, everyone. We are going to try recording this, and we will let you know if the sound quality is good, and we will have it available to the attendees and for others, hopefully on our website. But just a couple of things. We have an audience here and we have an audience via webinar. We apologize if there's any background noise. If you are having some issues with hearing, there is a chat box and you can type a message to us and we will try to remedy any of the problems. There is going to be some pre and post. Unfortunately, the webinar people will not be able to get the pre, but there will be a post presentation evaluation that you will get via email. So I'm going to turn it over now to Christina Allen, and she's going to do the presentation.
Okay. Hi, everyone. Good morning. Happy Valentine's Day. Thank you for coming. Thank you for having me. This is something that I arranged with the help of Sharon. We are hoping to make some additional changes to the intake form to the Choices program to make sure that we're aware of our veterans and that we're connecting them with VA healthcare whenever we can. And I plan to continue working with Sharon in the Choices program to help support you guys in these efforts. So you're not alone with this. As Sharon said, my name is Christina Allen. I am a suicide prevention coordinator at the West Haven VA Hospital. I've been with the VA for about 5 years. Many years ago, I was a trained Choices counselor myself, so I have some idea of what you guys are doing and how important this work is. You are the kind of access point for a lot of veterans who are struggling and seeking connection with care and trying to get their full health care benefits. So I think this is a great group of people to attend this training. You can see on your desks I've handed out some material. Most of the material has the phone number for the Veterans Crisis Line. If you work in a program or at an agency where you think it would be helpful to have an abundance of these sort of materials to hand out to veterans or family or friends of veterans, just let me know. I can get you like those magnets, or there's wallet cards over on the table there. I can get you those in mass quantities. So just let me know if this is something you'd be interested in. And for people listening in on the webinar too, unfortunately you can't see the materials that I'm handing out, but if you would like some sent to you, hoping you have at least Sharon's email so that we could arrange for that. All right, so we're going to get started. We're not advancing slides. What's this? Oh, no. If you have it set up to do it over there, you can do it over there.
No, I don't. Let me just make sure you're on. Okay. Well, that concludes our presentation. Just let them know if anything works,
but technical difficulties.
You want to go outside and just do a PowerPoint? I can't see which one from here that you might want.
No, because this worked great yesterday and this morning.
Of course. If you ladies that just came in, if you could take a minute to fill out that pre-training evaluation that's on your desk, that would be great. And we should be getting started soon.
Which one you want to take it first and second?
Just hit anyone. Okay, and start from current slide. Yeah. was just a little tired. We've been on for about 45 minutes, so it probably just had a lag.
Okay, perfect. Okay, thank you. So over the next hour or so, these are going to be our objectives. So you're going to learn a little bit about what the VA does for suicide prevention. We're going to talk about suicide risk in older adults. We're going to talk about how to help somebody who's having a crisis. And then we're going to do a piece on access to VA services. That's going to be a smaller piece of the presentation. I was talking with Sharon, and I'm happy to come back and do something more in depth about access to VA services. Training is going to be available on an ongoing basis, so if there's any pieces here that people feel need to be fleshed out some more or deserve some additional attention, I'm happy to come back at any time. So these are some of the things that the VA does for suicide prevention. As I mentioned, I'm a suicide prevention coordinator. Every VA medical center across the country has at least one suicide prevention coordinator. We do screening and assessments to identify veterans who are at high risk for suicide. We handle consults that have been generated by the Veterans Crisis Line. We help veterans at high risk receive an enhanced level of care. So once the VA has identified somebody as high risk, there's then kind of a set of procedures and additional services that are provided to that person. And we also monitor those veterans to make sure that they're getting the enhanced care. So we're watching every single veteran who has been identified as high risk. We're making sure that they're getting appointments on a weekly basis. We're doing something called mental health safety planning with them. We're outreaching them if they're missing appointments, so we're calling them. And we're just kind of monitoring them in general to make sure that they're getting the care that they need. We also do reporting and tracking on our veterans. So anytime we learn of any sort of suicidal behavior, suicide attempt, death by suicide, we report those into a larger database, as well as keeping those numbers on a local level. That larger database is analyzed by the National Suicide Prevention Program, and that's how we get kind of our larger suicide data reports. That's where we'll get some of the statistics that I'm going to mention in a few minutes. And that's also the way that we help identify trends in veterans' suicidal behavior. And that's also where we would target our interventions at. So if we're seeing anything that's happening across the country, then we'll want to see if there's something we might be able to do differently to address that. And then lastly, we do consultation and training within the hospital. That's a big piece of what I do, but then also getting out of the hospital and into the community. Over the past couple months, I've been at Middlesex Hospital and Silver Hills Hospital, so I'll go anywhere in Connecticut where they have an interest in this sort of training. And we do clinical and non-clinical presentations. So I'm sure everyone's heard that veterans do have a higher rate of suicide than civilians. If you haven't heard that, you must be under a rock somewhere because it is everywhere. So with that being said, we know that this problem is far from solved. We're continuing to try and put new initiatives into place. The Veterans Crisis Line has expanded greatly. They've added a second call center. They've hired a ton more staff. We've started a same-day access to care initiative so that if a veteran walks into the hospital or cold calls our facility and is not currently enrolled in services, but they say they want to speak with somebody in mental health, they will have either an in-person or phone evaluation done within 24 hours. We're doing a lot with our veterans with substance use disorders. Substance use is a huge risk factor for suicide, so there's been a lot of education around things like naloxone to reverse opioid overdose. We do a lot of telemental health work. So if you're somewhere in a rural part of Connecticut and you can't easily get to one of the main hospitals where the abundance of services are, but you still want a therapist on a semi-regular basis, we may be able to arrange for you to come into one of our smaller community sites. Those are called C-Box. I'll talk about those more in a little bit. And you can see your provider over telemental health. So you're basically sitting down, meeting with your provider through a video screen, kind of like a Skype deal. And that's really helpful for some of our veterans who just can't get into the main hospital. And then, of course, we're always continuing to make partnerships with our community agencies. There are so many veterans in Connecticut who are not enrolled in VA healthcare but are probably eligible for it. And we're not going to know about those people unless we're getting out here into the community and making sure that we have some sort of relationship with the community providers. Locally at the hospital, one of the recent initiatives was a medication take-back program, so that we now have a drop box for veterans to come and drop off any unused or unwanted medications. So that would be particularly important for somebody who's been identified as high risk. So that would kind of fall into restricting access to lethal means. We would make sure that that person knows that they can come and dispose of any additional medications, which would hopefully reduce the chances that they would do something impulsive such as overdose. Before we go any further, I didn't ask when we started, do we have any veterans in this room? No? Okay, I usually ask when we first start, and I'm always surprised. We usually have at least one. We're going to go, as we go on, we're going to do some more kind of statistics around suicide deaths. We're going to talk about helping people in crisis. Sometimes this stuff can be uncomfortable. If anybody's having any discomfort, if you feel like you need to excuse yourself, go ahead. If there's anything that you want to talk to me about afterwards, I'm happy to talk. I'm here, okay? So the Veterans Crisis Line that I have mentioned a few times, I'm going to mention it again because it's a huge resource. It's available 24 hours a day, 7 days a week. And as you can see, since it started about 9 years ago, they've handled over 2.5 million calls. Has anyone here previously heard of the Veterans Crisis Line? Raise your hand if you've heard of it before, if you don't mind. I just want to. Okay, so only one person. Huh? That's good, actually, because now everyone else is learning about something that they didn't know before. When you call the Veterans Crisis Line, you are connected to a responder 24 hours a day, 7 days a week. There's no waiting. You make the call. You do have to press 1 to indicate that you're a veteran. Otherwise, the main phone number, which is on some of your materials, is the same number for the National Suicide Lifeline. So that would be a resource that you would give to any maybe civilian that you're working with. But if somebody is a veteran, the important thing to remember is that you ask them to press 1 so that they're routed to the Veteran Call Center. When they're routed to the Veteran Call Center, they're going to be greeted by a responder who has training specific to veterans issues. 35%, approximately 35% of the responders are also veterans themselves. So if a veteran calls in, they always have the option to ask to speak to a veteran. That is a huge deal for some veterans. Can make somebody feel a lot more comfortable opening up when they're talking to somebody who has similar experiences. The Veterans Crisis Line was also the subject of an award-winning HBO documentary a couple years ago. I want to say 3-4 years ago at this point. I think that gave a lot of exposure. That's how a lot of people came to know about the Veterans Crisis Line. I have a quick video clip on the Veterans Crisis Line, and it should work as long as we're connected to Wi-Fi, so let's hope this works out. Oh no.
Can you
Yeah.
go back one page and I'll try it again? Because I don't have a link to click to try again.
It's not letting me go faster. No, oh, that went back to the beginning. All right. Okay, we can move on without it. So you can find this on YouTube if you want to take a look. That was a like 3-minute segment of the HBO documentary, and it's called Veterans Press 1. It's still floating around like on demand and Netflix, whatever. There's a million ways to get TV content nowadays. So it's something that I would definitely recommend checking out. It's a behind-the-scenes look at what happens when somebody calls the crisis line. It's a really well-done documentary. I'm not just saying that because I work for the VA. So now we're going to get into some of the statistics, and then we're going to talk about what to do if you encounter somebody in crisis. I don't like to go too heavy into statistics because they can be interpreted in a number of different ways, but this is some pretty straightforward stuff here. So in the United States, we have over 42,000 deaths by suicide every single year. When I first learned that number, it was something that seemed kind of hard to put into context. So one way that helped me was to learn that there was less than 17,000 deaths from homicide on any given year in the United States. So we're looking at 17,000 deaths from homicide compared to over 42,000 deaths by suicide. Suicide is obviously a much larger public health problem. However, I think it's fair to say that we hear about murder much more than we hear about death by suicide. Any thoughts on why that is?
Well, I know the police in Fairfield don't report suicide. That's just, they keep that in the news.
Okay.
I don't know why.
Any other ideas on why?
Shame.
Shame, yeah. So there's major stigma around suicide. There's lots of shame, right? But if we keep a problem like this swept under the rug and associated with all this shame, nothing's going to change. This is going to continue. These rates are going to continue. They haven't changed much over the last 20 years. They've actually increased. Over the last few years, they've increased at a rate that's been higher than ever. So the problem's only getting larger, but I don't hear people talking about it more. It's the 10th leading cause of death in the United States. It's actually the 2nd leading cause of death for people ages 15 to 24. Only under unintentional accidents like car accidents, things like that. The rates in older adults are also really staggering, so that's what we're going to get into in this presentation. I did one of these. Okay, so remember I was talking about before how we put all of our statistics into this database and then they're looked at by the National Suicide Prevention Program. They just did one of their largest data compilations and analysis that they've ever done over this past summer, and what they've been able to tell us is that there's approximately 20 veterans dying by suicide in the United States every single day. There are 18% of suicides nationally, but only 8.5% of the population. Just by being a veteran, so having military service, nothing else, puts you at 21% greater risk for suicide than a civilian. And another important factor to note is that 66% of all veteran deaths by suicide were the result of a firearm injury. So that's a huge piece in this equation. Suicide in our aging veteran population. We have a huge aging veteran population, and that's only going to increase. A lot of our Vietnam era veterans are retiring.
seeking VA health care for the first time. And I imagine that these are the people that you guys might come across as well as choices counselors. So in 2014, approximately 65% of all veteran deaths by suicide were in those ages 50 and older. And something else that we know is that elderly veterans are less likely to seek out mental health services. So these are the people that we need to be looking for. We need to know what to look out for so that we can identify these people. The stigma for them is even so much greater than it is for our newly returning veterans. The stigma is definitely still there for our newer veterans, but those who served in Vietnam, it takes a lot for them to get connected to treatment. Another thing that's important to note about our older veterans is that sometimes they'll go to maybe their general practitioner and they'll start complaining of stomach pains, headaches, things like this, and there might be no reason for it, and they might be complaining of these things over and over again. Sometimes they don't quite know how to put a finger on what depression is, what it feels like, what mental health issues are, so they'll often go in with somatic complaints, and that will actually be something like depression or anxiety manifesting itself in a different way. Another important point about older adults is that they make more lethal attempts than younger people. So when we're studying suicide rates in older adults, we're seeing that they're more likely to use firearms, they're more isolated, and they're more planful, right? So when younger people are making suicide attempts, it's often done in an impulsive way, and it's often done in a way where there's a chance that they can be found and rescued, brought to a hospital. When you're an 85-year-old widow alone at home and you take an overdose, there's a good chance that nobody's going to find you for days, right? So that makes these attempts much more lethal. So now that we've talked about all these depressing statistics, one thing that is a silver lining here is that the suicide rates for veterans using VA healthcare services, although it is rising, it's rising slower than those who are unconnected to VA healthcare services. So I can't tell you exactly what's working, but we're doing something right because those who are connected to healthcare services are not dying by the same rate as those who are not. So suicide is everybody's business. I firmly do believe this. It's a public health problem. Although you may not have a mental health background, that doesn't mean that you're not going to encounter somebody who's having thoughts of suicide. It's much more common than we realize. And some statistics to back this up is that only 15% of people who die by suicide have seen a mental health professional in the month of their death. But 75% saw a primary care doctor within 3 months of dying by suicide. So that's important to remember, is that these are people who are hitting all different points of the system, not necessarily mental health. So it's really important that we're looking at this on a larger systems level and that you guys as choices counselors know some of the warning signs and know what to look for. We're going to talk about a couple myths around suicide. And this is audience participation portion, so speak up, guys. Is this a myth or a fact? Yeah, I did tell you to speak up, so. Asking about suicide will plant the idea in a person's head. We already had one person say myth. Myth? Everyone's saying myth? Oh, no. I don't get to argue with anyone? Okay. So it is a myth. This is what you need to remember. Asking somebody about suicide does not create suicidal thoughts. That is completely false. And one way to think about this is that say somebody walks into a doctor's office and the doctor is doing like a review of systems and asks them, do you have any chest pain? Is it possible that that question is going to give the person chest pain? No, not unless they're like really scared of doctors, but generally no, that's not possible. You can't plant this stuff into somebody's head the same way that you can't cause somebody to have a medical condition by asking them about it, okay? And actually asking somebody about thoughts of suicide gives them permission to talk about it, because most people, especially older adults, are not going to freely give up this sort of information. So we need to be kind of looking for red flags, looking for risk factors and warning signs, and knowing when it might be the right time to ask somebody if they're having thoughts of suicide. I think we got one more myth, and well, it could be a fact. All right. If somebody really wants to die by suicide, there is nothing you can do about it. Any thoughts? I heard one myth. I heard one person say not totally sure. It's a tricky one. Okay. Okay. It's a myth. So 99.9% of the time when somebody's thinking about suicide, they're highly ambivalent. They're really struggling, trying to decide whether or not they want to live or die. Even if they have resigned themselves, that's usually an acute, time-limited period of crisis. So the idea is if you can help somebody kind of get over that hurdle, those thoughts of suicide are going to dissipate. It's going to come back down. They might still be there somewhere in the background, but that person is not going to stay resigned to kill themselves for an extended period of time. So there is almost always a window there where we can intervene and get somebody help. When I talk about this, one of the ways to really highlight this too is the story of Kevin Hines. And I have a video clip of him too, but I don't know if it's going to work now. Has anybody heard of Kevin Hines before? He's a gentleman who survived a jump off the Golden Gate Bridge. Only 1% of people live after jumping off the Golden Gate Bridge. So long story short, Kevin had bipolar illness, was hearing some voices, had started thinking about suicide, decided he was going to jump off the Golden Gate Bridge, took a bus down to the Golden Gate Bridge, became very distraught, started second thinking this, said he was pacing up and down the Golden Gate Bridge, very upset, tearful, hoping that somebody was going to stop him and ask him if he was all right. And I've heard Kevin tell this story himself. It's like it gives you goosebumps. So as he was pacing up and down the bridge, he said to himself, if one person stops and asks me if I'm okay, I'm going to tell them, no, I'm not okay. I need help now. I'm thinking about jumping. So a woman came up and approached him, and he thought, okay, this is it. She asked him to take a picture. She was a tourist. And he said he was tearful at this point, so he's visibly upset. He takes the picture, gives the woman her camera back, and proceeds to jump off the bridge. Somehow, miraculously, he lived. Not only did he live, he's a pretty capable person now. He's not paralyzed. He's fully functional. I know his story is just incredible. He was found. There happened to be like a passing Coast Guard boat when he hit the water, and they were able to get to him immediately. So now he goes around and tells his story and talks about how important it is that we care for each other, and that just by asking a simple question, you can save somebody's life. So now we're going to talk about Operation SAVE. That's one of the brochures that people have out on their desk. Operation SAVE is the military's way to help somebody act with care and compassion if they encounter a person in a suicidal crisis. SAVE is an acronym. The military loves acronyms. The VA loves acronyms. So it's going to help you kind of remember each of these steps. We're going to go through these. Operation SAVE is something that we teach to our veterans so that they might be able to help each other. It's also something that we teach to staff at our veterans housing program. Let's
get rid of that.
try it. Okay, we're still good. So yeah, this is something that we try and teach to as many people as possible. And you can see there, S is for the signs of suicidal thinking. A is for asking questions. V is for validating the experience. And E is for encouraging treatment and expediting help. And a lot of these, a lot of the way that I'm speaking and a lot of the way that these slides are set up is towards veterans, but something like this is not only veteran specific. This is something that would work with any person in a crisis. So the importance of identifying someone who's suicidal. There's no single profile to figure out who is or isn't a suicidal person. We think about people who have died by suicide. It affects anyone from somebody in very low socioeconomic status up to celebrities. We know it happens. So anyone could be suicidal. We can't look at somebody and say, oh, you look put together. You wouldn't have thoughts of suicide. It doesn't work like that. Some signs are obvious. Others are not. The idea is that when you recognize signs, it's really important to ask some more questions because you never know who might need help. So some acute signs of suicidal thinking. And again, some of these are going to seem super obvious, but I've seen people, even nurses, ignore some of these things, and then we end up with like a near miss down the road. So if anybody's threatening to kill themselves, that needs more attention, even if it's done in kind of a flippant, offhand way. They might be saying it like that to kind of divert attention, but it still is something that needs more follow-up. Anybody who's looking for ways to kill themselves. So somebody who's talking about trying to find out how to get a gun, somebody that's talking about medications that they've been hoarding, anybody who's writing about death, dying, or suicide. These are acute warning signs. So these are situations where we would want to get that person help as soon as possible. So these are some less obvious signs of suicidal thinking. And these signs don't necessarily equate to somebody who's having suicidal thoughts, but we would look at this kind of in the context of what somebody's going through. So increasing drug or alcohol use, as I said before, substance abuse and suicide are really kind of tightly linked together. Withdrawing from friends, family, and society. Difficulty adjusting to life changes or losses, so that's huge for our older adults, right? People who have lost a spouse of many, many years, people who have lost sense of purpose after they stopped working, people maybe who lost a home that they lived in since they were born because of financial strain, things like this have a huge effect on people's mood. Anxiety, agitation, being reckless, engaging in risky activities, and then difficulty sleeping or sleeping all the time, which is also a symptom of depression, kind of a larger piece of this. And then giving away possessions. If somebody all of a sudden decides that they're writing a will and they are picking out what family member is getting what, that could mean they're having thoughts of suicide. And I remember when I first learned about that sign, I thought that was like something that happened in the movies or on TV, but it happens in real life. I have had 2 family members of older veterans call me and say, you know, there's been no change in my father's health status, but all of a sudden he decided who's going to get every single thing that he owns. And it turns out that person was starting to come up with a plan for suicide. So it's something to look at. Ask questions. So I don't want to downplay how difficult it can be to ask somebody about thoughts of suicide. I ask multiple people every single day, and it still can be an uncomfortable conversation. I can tell you that the more you do it, the more comfortable you get with it. Even practicing it will be helpful, but it's just one of those things that can kind of get stuck in your throat there. You know, it's not easy. Important to remember that if you're asking somebody about suicide, you need to try and manage your own reaction. So be prepared if they say that they are having thoughts of suicide. Try not to freak out, okay? Try and stay calm. Try and be empathetic. Try and be attentive and let them know that you're here for them, okay? I also can't stress the importance enough of asking directly, okay? So asking somebody about wanting to hurt themselves is not the same as asking them if they're having thoughts of suicide or if they're thinking of killing themselves. Okay, those are 2 different things. Especially in the mental health population, there's lots of people who have thoughts of self-harm or self-harm behavior, but would never have thoughts of suicide. And it also works vice versa, okay? So there's lots of people who are having thoughts of suicide, but don't equate that to self-harm, okay? So you gotta be straightforward. The easiest way to ask is, are you thinking of killing yourself? Are you having thoughts of suicide? Be direct. And then some of the things that we were talking about before, stay calm, listen. You don't need to try and convince them not to do it. You don't need to try and tell them why it's not the right thing to do. So don't get into a power struggle or an argument with somebody. Be open, supportive, encouraging. One other thing to note, and I've heard people ask like this, and it's not the right way to ask. So what do you think somebody's going to answer if you say, you're not thinking of killing yourself, are you? They're going to say no, yeah, because you told them already that the answer is no, right? So the way that you ask makes a difference. And then validation. So if somebody's having thoughts of suicide, they're probably very ashamed, embarrassed. This is probably something that's very difficult for them to deal with. So you just want to kind of acknowledge their feelings, let them know that you're there to help, and accept the situation for what it is. You want to make sure that they feel like they're being heard and listened to. Encouraging treatment. So if somebody's having thoughts of suicide, remind them that there is help available. Treatment can work. For somebody who's older and having a tough time, you might want to try and normalize this. Seeking help for thoughts of suicide is the same as seeking help for any sort of medical problem. Okay, so this is a medical issue, and there are people who can help. If somebody tells you they tried treatment before and it didn't work, well, that may be true, but that doesn't matter because it could work this time. Expedite getting help. So wherever you are, whatever agency you're in, whatever setting you're in, if you're doing choices counseling, know what you're supposed to do if you end up speaking with somebody who tells you they're having thoughts of suicide. There's some clear situations of such as if anybody's ever telling you that they're having thoughts of suicide and they have a plan and they're intending to act on that plan, that's somebody that you need to call emergency services for and get an ambulance out to their house, right? That needs immediate attention. If somebody tells you that they're struggling and they've had thoughts of suicide but don't have any plan or intention to act on it, that's somebody that you need to refer to mental health treatment, or that will be a situation, if it's a veteran, that would be a situation where you could contact either me or the Veterans Crisis Line to get some help. I'm not sure if I mentioned clearly before, but the Veterans Crisis Line is also for family, friends, caregivers of veterans. It could also work for you as a choices counselor. If you're dealing with a veteran who needs some guidance, you can call the crisis line and say, you know, this is what the veteran told me, I'm not quite sure what to do now. Or you could encourage your veteran to call the crisis line themselves. If it's a situation where you think it could wait for like a response from me, I'm happy to be a resource and follow up with that veteran, okay? So emergency situations, we just talked about that. So if you're with somebody who's saying they have plan and intent for suicide, calling me is not going to help. We need to get emergency services to that person. All right. So we only have about, I think that clock is right? So about 15 more minutes, we're going to spend some time talking about the VA healthcare system, the enigma that it is, and we'll see if there's any way that I can help you guys kind of figure things out. Before we go on to the next piece, did anybody have any questions, thoughts, concerns about what we have been talking about?
You mentioned mental health hubs before.
Mm-hmm.
Can a veteran Skype from home, or do they have to go to a hub?
Yeah.
I don't know if you need to repeat the question.
Okay, thank you. So the question was, can a veteran get mental health, the telemental health treatment from home, or do they need to go to a VA facility? And the answer is that they do need to go to a VA facility, but the idea is that it's more available because we put telemental health into our community clinics. Those are the CBOCs. We have 6 in Connecticut, right? So we have the 2 main hospitals in Connecticut, West Haven and Newington, and then we have 6 smaller community clinics scattered all throughout the state. So it's very unlikely that you're going to be too far to get to treatment.
And you mentioned the phone number can be used for suicides. Just if it's not a vet, don't press number 1. Exactly.
So the National Suicide Lifeline is the same number as the Veterans Crisis Line. It's 800-273-8255. If you call that number, you will be connected to the National Suicide Lifeline. That can be used by anyone. If you press option 1, you will be routed to the Veterans Crisis Line, okay? And we call it the crisis line, so you don't necessarily have to be having thoughts of suicide to call. We get close to 40 calls a month in Connecticut, and I'm following up with those calls, and some of them are true crisis. Others are somebody who can't figure out how to get to their next appointment and really want to make sure they make it. There's been all sorts of reasons. I'm thinking of some funny ones right now. But people call for all sorts of reasons. We're not going to tell them that they can't call the crisis line. If they need assistance with the VA, they can call the crisis line, okay? Anything else before we go further into structure?
Could you give us a listing or tell us where to find the locations of the CBOCs or the death centers or the residential rehab programs?
Yep. So your best resource there is going to be www.va.gov. They have like a location finder. You can go to, like if you go to Connecticut on the website, I can give you some more, this is kind of general information, I can try and give you some more detailed information. But if you can navigate a website, okay, you can go to the va.gov, get to the Connecticut page, and then once you're on the Connecticut page, it will give you a listing of what services we have, and that will include the community clinics, our residential program. The community clinics are Winstead, Willimantic, Stanford, Danbury, Waterbury, and I feel like there may be one more that I'm forgetting, but they're all out there. So it's very rare that somebody's more than like 30 miles away from VA. There are some services available at the main hospitals in West Haven and Newington that are not going to be available at these clinics. The West Haven Hospital also has a 24-hour medical emergency room as well as a 24-hour psychiatric emergency room. So we have a standalone psychiatric emergency room in West Haven. So if somebody needs an emergency level of care, West Haven is going to be their best bet unless they need help right away and they live in some corner of Connecticut, then they should get to a local ER. And then we collaborate with any community hospital that has a veteran. I spend a lot of time talking to community hospitals and making sure that the veterans get plugged back in for services and that their providers at the VA stay in the loop while they're out in the community hospital. One of the important things to remember is that military service does not equate to eligibility for VA health care. So there's many people out there who may be veterans but are not eligible for VA health care. It's really important, kind of the first step is to figure out whether or not you're eligible for care. If you've already received services from the VA at any point, then you're eligible for care and you can kind of skip that part. But if somebody calls you and they say they've served in the military but they don't have VA health care, then before you go any further, you want to help them find out if they're eligible. You're likely going to need your DD-214 to determine eligibility. DD-214 is your discharge paperwork from the military. It's going to have your dates of service and it's going to have your type of discharge. So there are situations where people are ineligible for care because of something like a dishonorable discharge. But there are so many exceptions to these rules, it would take days to explain all of them to you. So what we tend to say is that one person's eligibility is one person's eligibility. You can't make any sort of generalizations here. Because one person might be ineligible for a dishonorable discharge, and then we might have somebody else who has a history of sexual trauma during their military service. And even though they have a dishonorable discharge, they might still be eligible for trauma treatment. So it's very complex. If you can get somebody to go in person to West Haven or Newington with their DD-214, their discharge paperwork, that's going to be the clearest way to determine their eligibility. There are a couple other ways you can do it. There's a website that you can apply for VA health care. That's not going to tell you right away if you're eligible. There is a little bit of a turnaround time there. There's also a phone number that you can call to give your information, and then they will still have to send you a form to sign, which you send back to them. So those are definitely less direct ways to determine your eligibility. At any time, if somebody can present in person, that's the way that I would encourage them to do so. We have a lot of veterans also who call the crisis line because they can't figure out their eligibility, and then I'll work with them to try and help sort that out. I don't do it directly. I just try and get them access to the eligibility office. There is a lot of things that are definitely over my head when it comes to eligibility. We have local eligibility offices in West Haven and Newington. Those are the extensions down there. So if you call that number and put one of those extensions in, you will end up speaking with somebody in a VA eligibility office, okay? And they won't be able to tell you whether or not a veteran's eligible, but if you can get the veteran connected directly with that office, that would be really helpful for them. Any questions on this eligibility?
Can you say something about service connection?
Sure, I would love to. Service connection. So you might hear people say that they're service-connected veterans, and service connection means that you receive monetary compensation for a physical or mental health condition that occurred during your military service, okay? So if you are done serving and you say, you know, I broke my ankle during whatever, during my service, and I'm never going to be able to walk the same. It's really impeding my quality of life. You could potentially get service connected for your ankle injury. And then there's ratings from 0% to 100%. So depending on how you get rated, so how much that injury affects your quality of life, you'll end up getting a percent. And each percent is assigned a monetary value, and that's how much compensation you will get every month. Service connection is separate from eligibility, right? So there's tons of veterans who are eligible for VA health care but don't get that monthly compensation. They came out of their service without any lasting injuries. But then there's also a good group of veterans who get that monthly compensation. The higher your service connection claim is, the more kind of benefits that you're eligible for. So you get fast tracked to certain types of care. You're in a higher priority group. And like I said, service connection can be for any sort of injury, physical or mental health. So if you are speaking with a veteran who's talking about a service-related injury that they never sought treatment for, they can speak with a veteran service officer who will help them make a claim for service connection. Veteran service officers are located usually at places like American Legions. They'll usually have a veteran service officer. We do have one on site in the hospital. And again, I'm happy to act as a resource. So if you have somebody that you encounter that you think has a case for a service connection claim, you can let me know, and I'll help try and point you in the right direction.
Follow up to that. Service connection can change.
Yeah. Yeah. So say you put in a claim for that ankle injury and they rate you at 20%. Then you end up getting some sort of surgery that really corrects the problem, and it's no longer affecting your life. It's no longer a physical nuisance for you. You may get reviewed again, and then they may end up decreasing your service connection. They can go up or down. So even say you filed for post-traumatic stress disorder shortly after separating from the military, and you got rated at 50%, then you go to get reviewed again, and your symptoms are so much worse than they were when you first got back. That service connection may end up going up. Okay. People who are 70% service connected and above are eligible for VA nursing home placement, okay? And that is contract nursing home placement. We don't have our own nursing home. Side note too, we are not the Rocky Hill State Veterans Home. That is a state entity. It's separate from the VA as a federal healthcare system. So we do have a working relationship with them, but we can't necessarily get somebody into the Rocky Hill Veterans Home. That's a whole different process. The application is, I've Googled it before, it's pretty easy to find. It can be found online. But we don't have any direct kind of pathway there. The nursing homes that we work with are through contract programs. So it's the nursing homes that you may already be familiar with. There's just a listing of nursing homes, not that many, it's probably under 20 that we have a contract with, and we will pay for a veteran to live there if they are 70% service connected or higher. And again, if that's something that's kind of complicated, if you have somebody who you think might be eligible for a contract nursing home placement, give me a call and I'll give you like the contract nursing home manager and ask her to reach out to that veteran. You can do something like that. Primary care is kind of a gateway to services at the VA. So they act in what's called PACT teams, Patient Aligned Care Team. So there's going to be a doctor, a nurse, a social worker, medical support assistant. That's all part of your PACT team. If you're assigned to a primary care doctor at the VA, that PACT team can help you access other services. So if you're talking to somebody who's assigned to a primary care doctor at the VA and still having trouble accessing some services, what they probably need to do is seek out an appointment with the social worker that's on that team, and hopefully he or she can help get that veteran whatever services they need. I am not the expert on home and community-based care programs. We have a lot. Again, this is a situation where I can probably help point you in the right direction. We do have a home-based primary care team, which is somewhat similar to the Connecticut home care program in that there's a nurse and a social worker who go out and provide some in-home services. It's a small program. A referral would need to be made by the veteran's primary care doctor. And there's a small group of veterans who are eligible for those sort of services. Ideally, if somebody needed a lot of services, we would try and refer them to the Connecticut home care program. We do have purchased care, home health care, homemakers, aides, adult daycare, that sort of thing. Those are in really, there has to be kind of extenuating circumstances there for somebody to get purchased care by the VA. So again, if you have somebody who you think might be a good candidate, give me a call and I'll help try and figure it out. We have a small respite program at the VA. Again, that would be something that somebody's primary care doctor would refer them to, or their social worker. And then we do have a small hospice and palliative care unit. We also have an inpatient medical units at the VA hospital in West Haven. Pretty small. I can't remember how many beds we have. Not that many. There's only like several inpatient medical units. So yeah, just real quickly on home and community-based care. You want to try and get somebody in via their primary care doctor. Mental health treatment. Okay, so this is something that I actually do know a lot about. Like I said before, we have a dedicated psychiatric emergency room that's available 24 hours, 7 days a week. We have an inpatient psychiatric unit at the West Haven Hospital. It's small, but it's there, fully functioning, 16 beds. We have a residential rehab program at the VA hospital in West Haven. I think they have about 20-something beds. That's a 21-day program. We do get older adults in that program quite frequently, and that's for people who need support while they're receiving intensive mental health or substance abuse treatment. We also have a residential PTSD program in West Haven. It's tiny. I think there's 6 beds in that program. But we work with other VAs across the country if somebody needs kind of specialized residential treatment. So outpatient options, there's individual and group therapy, there's medication management, there's specialized treatment for things like PTSD and military sexual trauma. We have therapeutic day programs for people with mental health problems as well as substance abuse issues. We have some intensive case management programs for our veterans with chronic homelessness or severe mental illness. So we'll actually go out into the community to try and help those veterans make sure that they're connecting to care. And of course, we try and do as much evidence-based treatment as possible. So we have things like cognitive behavioral therapy. We do a lot of cognitive processing therapy for people with trauma-related conditions. The list could go on and on. So that's kind of in a nutshell what we have. This would definitely be an area where I could help connect somebody. So if you end up talking to a veteran who has VA healthcare services but thinks that they could use some mental health treatment, I'm happy to follow up with that person and try and figure out where they would fit into the system. And Kevin Hines' story, YouTube it, okay? It's good. Oh, you want, sorry?
Can you just repeat the bed availability again as the different programs?
Yeah, sure. Our inpatient psych unit is tiny. There's only 16 beds right now. The residential rehab program has 20-something beds. I'm not sure, maybe around 25. The PTSD program only has 6 beds right now. And then our medical unit, I'm not entirely sure, but I would have to guess maybe around 200 beds. It can't be much.
Those are all West Haven.
So that's all in West Haven. Newington has no inpatient units, okay? They have an urgent care center, and they have almost all the outpatient services that West Haven has, but they have no inpatient units there. All right. Well, we've already gone a few minutes over, but yeah, if you want to check out Kevin Hines, it's easy enough to find his story on YouTube. I think that's about all that we have. There's some resources on the last page of the PowerPoint. There's my email address and phone number. I am 100% serious. If you need anything, give me a call or email me. I'm happy to try and help. There's the Veterans Crisis Line. That's the phone number. There's also a website. Then there's something called MakeTheConnection.net. That's a website where veterans can go to hear stories about getting into care and recovery. It's been kind of like an inspirational website for people who are maybe hesitant to go into treatment. Something else to mention too, people probably already know about this, but the friendship line for older adults, if you're talking to somebody who's feeling particularly lonely, looking for more connection, a major thing that you can do is give them the phone number for the friendship line. It's considered a warm line, so there's no kind of trained mental health professionals, but it's people who can give kind of support, some social support to older adults who are feeling lonely. And that's a very important thing to mention too, because one of the most powerful ways that we can prevent suicide is by helping plug people into social support. So isolation, lack of connection are huge risk factors for suicide. So getting people involved in any way, getting them connected to the community is going to go a long way. Then there's the American Foundation for Suicide Prevention. We have 2 local chapters here in Connecticut. And then the place you would go if you want any sort of articles or research about suicide is the Suicide Prevention Resource Center. That's a great website. I'm on it almost every day. All right, thank you guys very much. Any parting questions? I'm going to pass out post-training evals. They shouldn't take too long. Thank you to everyone on the phone, too.
Can I get you to send some of these down to the VA campus?
Yeah, good.